going to try this thing and see how it sort of works. And I just want to talk to you a little bit about some of our experiences and some of the way we're trying to change the world in the management of neuroendocrine tumors and the way the world thinks about carcinoid tumors in particular. And I guess we'll just sort of jump right in, and then we'll kind of, maybe we can have some questions and stuff at the end if you guys want to do that, or stop me along the way and say, what did you tell you? What, you didn't really mean that, did you? And so anyhow, go ahead and, can you just like punch the little forward button, the little arrow? You know how to do that? There we go, good. All right, so I'm not a very good computer person, so I'm glad somebody else is doing it. I have a rotary phone at home. I'm a kind of an analog guy living in the digital world. And when college kids come over and want to borrow the phone, it's really great. I kind of see it's right over there. And then I wait and see what happens. And they pick up the phone, they look at it. How do you work this phone? There's no buttons. You spin the dial. So we're going to spin the dial tonight, if that's okay. So the traditional teaching for neuroendocrine tumors, such as carcinoid, well, they're slow growing. They don't require aggressive management. Don't worry about it. It's just carcinoid. And yeah, you may get sick later on, but we don't have to worry about that right now. We'll take care of you when you get symptomatic and you start having some problems. We'll give you some somatostatin analog of one kind or another. That means a drug called sandostatin, or now another drug called somatulene, which is kind of its first cousin. But they bind to receptors on these tumors and they help ameliorate some of the symptoms. If these tumors are making things that make you feel bad, it helps shut down the tumor from making those things that make you feel bad. Or in some cases, it can actually slow down the growth of these tumors. And the primary tumor, that means where it started, never mind where it spread to, but where it started, where the mothership was. If that's not causing you a problem, don't worry about it, don't take it out. If it's not causing a symptom, don't worry about it. Well, that concept bothers me a little bit because any place else we find cancer in people that's not bothering them, we say take it out, right? Colon cancer, you don't even know you have colon cancer until you get your colonoscopy and you have a malignant polyp. What do they say? They schedule for the OR next week. Breast lump, that big, not causing any problem, doesn't hurt. Hey, don't worry about it. No, you get scheduled for an excisional biopsy or a lumpectomy or something, et cetera, et cetera. I mean, any other kind of tumor you want to talk about, the treatment is, in general, if you can remove it, the best place for it's in the bucket. Well, if all we have is one bucket of water, wouldn't it be better to put out a campfire than a forest fire? That was my thinking, but I'm a simple surgeon. So, the problem is that based on traditional teachings, the 5-year survival in people that have this tumor, if you do nothing else, is about 30 to 50%. So half the people that have tumors in their liver are not going to be alive in 5 years if you don't do something. But still, the problem is, and here's part of the reason why I kind of got out of my own skin and had to get myself in somebody else's skin. The medical oncology folks, our friends that are in charge of taking care of folks that have disseminated and widespread cancer of various kinds, are dealing with people that for the most part have very aggressive tumors, and their problem is a 6 to 18 month problem from sick of them to come here. And then that's about as much as, if they can buy them an extra 18 months and maybe extend their survival out to 36 months, that's a win for them. With these patients, such as you do nothing and you're still alive 36 months later in many cases. So that's not a big emergency for them. So it's just a different sense of urgency. So how do you get to those guys and girls and make them feel urgent about what in their world, if the majority of the people you see have very highly lethal, very dangerous tumors, and this tumor is not so lethal, and in their world it's not so dangerous on the relative urgency scale. And so that's kind of where a lot of the thinking and the teaching sort of is based, is because of that background. You have to understand that those folks have a big problem that they're having to fix with other kinds of tumors that in this world seem to be less of a problem, at least less of an urgent problem. So they say, oh, we got time to worry about that. We'll worry about that later. And you kind of do and you kind of don't. We like to worry about it before we need to worry about it in a big way, let's worry about it in a little way, and maybe we can make a difference so that instead of looking at a 5-year situation, maybe we get 10, 15, or 20. That would be the goal. You can see a lot of grandkids over a 20-year period. So we started seeing some patients. I started working with a couple of colleagues who were real carcinoid experts. They developed their careers studying how to treat this disease, how to use this new drug when it first came out, this sandostatin drug, and what it did, how it worked, and what is it all about. And so they had quite a bit of experience and quite a bit of a following of patients from around the country who would come to see them to be treated for their carcinoid tumors and evaluated. But unfortunately, a lot of the patients came to them very late in their disease. And so I was the transplant surgeon at LSU, and the liver guy did liver transplants and moved organs around and stuff. They figured, well, if you can take a whole liver out and put another one in, you can probably patch this one up. So they would send me patients that had very complicated liver tumors where their carcinoid had spread to their liver, and asked me, could you see if you could do something for these folks? And I said, well, I don't know. And that was truly the case. We weren't sure what we could accomplish when we first started. But these patients were in very late stages of their disease. Most of them had already had major arrangements for hospice. They were already on morphine pain patches. They weren't able to work. They were not able to continue their activities of daily living. They needed pretty much round-the-clock help. And in our first 100 patients that were sent to us, several of them were sent because, well, they were losing weight, they couldn't eat, they had belly pain, and they had tumors this big in their liver. I mean, big as my head. And so from an oncologist perspective, somebody that's got that in their liver from any other kind of tumor, that's sort of the beginning of the end, if not the end of the end. It's not a fixable problem. What we found with these patients was that a third of them were not dying from their liver and their tumor, and that's not why they had lost 50 to 100 pounds and couldn't eat. They were dying because nobody had ever taken out their primary tumor in their gut, and now it was obstructing their gut, because a tumor in the bowel that's inside of a hollow tube, which is what the bowel is, knows only how to do one of three things. It can either obstruct, perforate, or bleed. And these things tend to either bleed or obstruct because they grow so slowly. They don't tend to burst and rupture the bowel. So these people had unrecognized bowel obstructions from their tumor that had never been taken out several years before, because we don't take out asymptomatic primaries. It's not causing a problem. They were dying of starvation. We fixed their bowel obstruction, took them the primary out, forget about the liver for now, let them get renourished, reinvigorated, and get their 50 to 100 pounds back to where they could, function. And then we could expect them to survive a big liver operation. Then we go take their big tumor in their liver out. 5% of these patients that were sent to us terminal went home with no evidence of disease when we were all done. It may take 2 or 3 operations to get there, but they had no evidence of tumor now anywhere in their body. And they were written off as terminal. There's not a lot of other diseases that you can say that about in terms of the cancer world, that you can sort of turn back the clock, so to speak. So well, that got us to sort of thinking, so well, gee whiz, if we got folks that are Cinderella's at the ball and it's 10 minutes to midnight, is there something we can do to turn the clock back to about 8 p.m. or so and let Cinderella keep dancing at the ball? And then when it gets to about 11:30, we'll do something else and turn it back again, because these tumors are slow growing enough many times that we can do something to sort of push the clock back and then let sort of nature catch up with it again and then do another thing. And so we started thinking about, well, what are some of these other things we can do, and how can we affect that? So one of the places where we found tumors that were in the belly like this, when they start in the gut, they tend to travel along the lymph node chains and the blood vessels that's nourishing the gut, and they go kind of backstream up back towards the liver. But sometimes they get all wrapped up around those blood vessels and all scrunched around them and squeeze them off. And so a lot of times the other thing we saw with patients where they weren't obstructed and blocked in their gut, the tumor was squeezing the blood supply to the intestine so much that every time they ate, they got what's called intestinal angina. It hurt when they ate because they couldn't get enough blood supply into their gut for the gut to work properly to digest their food when it had to have an increased demand. It's like when you get chest pain if you're trying to climb the mountains out there and you got not enough circulation to your heart, you're going to get angina. I'd get angina probably. I know I would. Trying to climb those mountains. I'm a flatlander. And so not enough blood flow to the intestine hurts. And it was hard to tell. Was there pain because the cancer was getting worse? Was it stuff going on in the liver? Were they blocked up because food couldn't get through? Or was it just they just didn't have enough circulation going? So we figured out ways to sort of pluck those tumors off of those blood vessels and let them relax and breathe again so more blood flow could come to the gut. And then the belly pain would go away. They could eat again and gain their weight back and then undergo maybe some more extensive treatment later. But nutritionally, they were a train wreck when they got there. So without nutrition, you know, you got to put fuel in the engine for the engine to run right, you know, and that's just the basic physiology of the way we're made. So anyway, that's kind of what we learned from about our first 85 to 100 cases or so, and we were working on this problem with our colleagues. So let's go on to the next one. So these things are thought to be rare tumors, but how rare really is rare? Well, neuroendocrine tumors are the second most common malignancy of the gastrointestinal tract from the mouth to the other end after regular old colon cancer. More common than esophageal cancer, more common than pancreatic cancer, more common than stomach cancer, more common than liver cancer, than primary cancer of the liver. That's not that rare, actually. What about lung carcinoids? Well, lung carcinoids, the ones that start in the bronchus, is the second most malignancy in the lung after regular old squamous cell lung cancer that you get from lighting up those coffin nails. Okay? So, it's not that rare, but any one practitioner may only have one or two in their practice because still the incidence is somewhere around 5 to 10 per 100,000. So, if you're a physician taking care of 50,000 patients, and I don't know of too many doctors that do, but in their population area they may be serving, they may have 2 carcinoid patients. That would be kind of how the numbers would shake out. So there's probably over 100,000 people in this country walking around right now that have a neuroendocrine tumor. So that's kind of a big number. And I guess the people that make Sandostatin would like to hear that number. At any rate, I digress. Next. Appendiceal carcinoids are the most common place where a general surgeon will see carcinoid. Carcinoid of the appendix is one of the more common places that shows up in the gut. And we used to think it's no big deal. A little carcinoid in the appendix typically is at the tip. It's about the size of a pea or a walnut. And if that's all it is and you take it out, forget about it. But turns out carcinoid tumors of the appendix, even though it's considered a benign disease and it's curative, 5% of the people that have that little small thing are going to die from that disease within 5 years. 5%. So it's not a totally harmless problem. What the problem is that not all carcinoids and what we're finding out are created equal. So not every little 1 centimeter tumor is the same like every other. Some are very well differentiated, grow very slowly, behave themselves, and act like a benign problem, sort of a slow growing thing. And others are very aggressive, grow very fast, metastasize quickly, and can be very lethal. And so the pathologist really has to look at that little thing in the appendix really carefully and tell you which kind is it? Or is it something in between? Because then, if it's one of the bad ones, those people are going to require much more aggressive surveillance and closer follow-up, and not just come back in 5 or 10 years when you have your metastasis to the liver. So, if they have spread outside the appendix, that's about a 30% mortality at 5 years. At least a third of those people are going to die from what was considered to be, quote, a benign disease. So it's not a small problem. Go ahead. And again, the thing about these tumors is if there's invasion of the base of the appendix, if it's already getting into the lymphatic channels or the blood vessel channels, those are the appendiceal carcinoids. In fact, any other kind of carcinoid that has that characteristic, that's kind of a bad thing. So that's what we want to ask the pathologists. They have to be part of this mix too. It's not just about the docs figuring out and finding it. When you happen to find one, even if it's an incidentaloma that just happened to be found when you were looking for something else, and you said, oh, there it is. Don't just take it out and forget about it. Make sure you make the pathologists tell you everything they can tell you about it to know what to do next. because that really can change the outcomes. Okay? And in general, we can kind of move through this a little quick. You can go ahead. In general, what it means is if you had a carcinoid of the appendix that was thought to be a little benign, nothing, but it had all of these bad features under the microscope, you have to go back to the operating room, even if they're home. You got to call them up and say, come on back to the hospital. We have to take half your colon out and do like a big formal cancer operation, or this thing's coming back in a bad way. And so that's why it's important to know those things. And then the other end of the GI tract, carcinoids of the rectum, are now on the increase in African Americans and Asians especially. They're typically little small things that are found on endoscopy, and those too can act very badly. They typically don't cause symptoms. They don't make chemicals that cause reactions in the body like some of the other types of tumors do, but they can spread very aggressively and be very bad actors, and so those folks also need close follow-up after those things are removed. And then if the tumor in the rectum is just local and that's nowhere else and you take it out, 90% of those people are going to be alive at 5 years, but on the flip side, I would say that means 10% of them aren't. For what's quoted benign disease. Well, that's not benign. That's 10% mortality. So we have to change how we think about that. And those people need to be followed. Yes, sir?
On your prior slide, you referred to PSA right in the middle of it?
Correct, yes. Some of the blood markers that we follow, we have these typical blood markers we follow for, excuse me, for neuroendocrine tumors, and most of the ones we follow are things like chemical compounds like chromogranin A is one of them everybody hears talk about, and 5-HI in the urine if people's tumors make this stuff that we can detect in the urine, and some other markers. But one of the unusual markers that sometimes pops up on rectal carcinoids and on carcinoids of the large intestine is PSA, which is the prostate antigen test for prostate problems and prostate cancer. We don't know why these tumors sometimes make that stuff, but if you test for it, sometimes you find it, and that becomes the barometer. If the levels of whatever the compound is you're measuring are very high, and you do something and either take the tumor out or treat them with some treatment, and the levels fall to very low and stay low, you feel pretty good about yourself and say, hey, we did some good here. And then if you follow those levels along and they start to rise again, then it's probably time to go do some investigations. And so it's like a poor man's CAT scan. It tells you something's going on. It's time to go get a scan, get a biopsy, get a scoping done or something. So it's a way of monitoring things of level of activity of disease. So each of these tumors makes their own particular markers that you have to go look for, and then those markers may not cause any symptoms whatsoever, but it's something we can pick up in the blood and then use it to track how we're doing and how the patient's doing. So that's kind of the thing about that. But basically, the more your tumor burden is what this means is that in rectal carcinoids, only about 25% of those patients are going to be alive at 5 years if you don't get real busy real soon and do something. Okay? So, and usually it requires, something requires a big operation is the main thing. So let's move on to the next thing. So midgut carcinoids are the ones that everybody, when they talk about carcinoid, okay, of the neuroendocrine tumor world, the neuroendocrine tumors are kind of divided into the carcinoid ones and the non-carcinoid ones like the pancreatic neuroendocrine tumors, which are called islet cell tumors. In the carcinoid world, they can be in the lung, in the bronchus, anywhere in the GI tract, and they kind of act a lot alike in that many times they make chemicals that then produce symptoms. The chemical they make most commonly is a stuff called serotonin, and serotonin makes you flush, makes you have diarrhea, makes you feel awful, makes you have palpitations, and eventually, if that stuff hangs around long enough and you have enough of it, it starts to chew up the valves in your heart and you get heart failure from it. That's not a good thing. One of the metabolites of serotonin is this stuff called 5-HIA, 5-hydroxyindoleacetic acid. We call it 5-HIA for short because it's a lot easier to say and quicker. And anyway, you can pick that up in the urine. So that's why people are asked to do a 24-hour urine test, and we can measure this stuff in the urine. If that's elevated, you have to, by infer, figure that, well, it's got to be coming from somewhere, and so it's probably a carcinoid tumor that's making that stuff. Pancreatic islet cell tumors, like carcinoid tumors, can be functional and they make stuff, are non-functional. They don't make stuff. The functional ones are the islet. Remember, the islets in the pancreas, that's where it makes your insulin. That's what keeps you from being a diabetic. That's what's keeping you from having a hyperglycemic surge right now and keeping your blood sugar from going to 400 after we just had this big meal with all these carbohydrates. Insulin is working right now, pounding your sugars down, driving them into your liver to make glycogen so you can store them up for tomorrow's big race. When you need that sugar, your liver is going to break it down and give you some sugar back. That's your glycogen stores. So everything you eat is processed in your gut, goes in the bloodstream, drain in the gut, goes right to the liver, where the liver then picks and sorts and keeps what you want to keep and get rid of what's bad. All right? So all that stuff's happening right there. Well, everything that's coming out of the pancreas also goes to the liver too. So insulin goes right into the liver where it hooks up with all those sugar molecules and tells the liver what to do with it. Well, the islets can make all kinds of stuff. They can make glucagon, which is like the opposite of insulin, which is what jacks your sugar up when it goes too low and you need a boost. Your glucagon kicks out and you break down some glycogen in your liver and break your sugar up. But if you make too much glucagon all the time, you're diabetic. It's a different kind of diabetes. It's not from people that don't make insulin, which is normal when we think about diabetes. This is diabetes due to an islet cell tumor. They also get weird skin rashes and very strange symptoms because of the high levels of glucagon. If the tumor makes too much insulin, it's called an insulinoma. And then those people have a problem with low blood sugar. They fall down with a blood sugar of 5 if they're not eating all the time, because they need to counteract that high dose of insulin. The insulin on switch is on, pedal to the metal all the time. So whatever the tumor makes is what we call it. If it makes it glucagon, it's a glucagonoma. If it makes gastrin, which makes your stomach make too much acid and burns holes in your stomach, we call it a gastrinoma, and so on. The problem is the majority of the tumors in the pancreas don't make anything. About maybe 20 or 30% of them will make stuff. The rest of them are just what we call silent, but they still grow and they metastasize and they go to your liver and they do all sort of bad things. So we got to deal with that. The ones in the gut, in general, if they're small, we say, well, they're not going to metastasize. But that's not always true. Size does matter in this disease, and the larger they are, the more likely they are to metastasize. So that they're found, and the thing is about 3 centimeters, about that big, it's almost 100% likelihood they've already left there and gone traveling somewhere. If they're only about 1 centimeter in size, then you got about a 40-50% chance that it hasn't left the bowel and it's still right there, and an operation could be curative. But basically, the longer it stays there, the longer you wait with that asymptomatic primary that's not blocked you up yet, it's still going to travel and spread and grow and do something if you wait long enough. Okay? And so the classic teaching was that the small ones had almost no risk of metastasis, the large ones had high risk, but now it looks like it's more important to look at what it looks like under the microscope and see does it have an aggressive looking biology or a more indolent looking biology. And so, again, pathologist has to be part of the team. They have to be involved. They have to help you. Okay? We look at a lot of things. When we put together our group of what we call a multi-specialty clinic, and we now have surgeons, medical oncologists, nuclear medicine physicians, radiologists, gastroenterologists, nutritionists, nurse practitioners to try and take care of patients that have a complex disease with complex manifestations, there's certain things we can do to try and help folks with that problem. We can offer all sorts of things like we can have a multidisciplinary case conference and everybody kind of scratches their head and looks at all the films and talks about, well, gee whiz, what are we going to do with this? How are we going to start making some progress to turn the clock back to 8 p.m. because Cinderella's about to leave the ball and it's getting close to midnight. We can look at MIBG therapy called targeted radiotherapy. These tumors light up sometimes, about 60% of them, with this molecule called MIBG. It's got a radioactive iodine, that's what the I stands for, that'll bind to the tumor and light it up and make a picture. And so if it lights up and makes a picture because enough radioactivity is bound to the tumor and shows up on the screen, what we do is we take advantage of that. Instead of giving a nice little picture dose, we give a big whopping treatment dose, just like 1,000 times the picture making dose. And so all that radioactivity gets sucked into the tumor by the receptors on it, just takes the radioactivity in with it and commits hara-kiri. It's not 100% kill, but But it's kind of like a guided missile. It'll go and swim around all over the body and find these tumors wherever they are and attach to them and zap them. So it buys us, again, it helps turn the clock back. So we can chemoembolize patients that means we take a catheter, put it in an artery, run up an artery to the liver. Instead of doing a heart cath, basically we're doing a liver cath. And so we squirt compounds up into the liver with a clotting agent to make them stick there. We can give a huge dose of chemotherapy, squirt it right into those tumors, and not have to poison the patient with systemic chemotherapy in the vein that goes all over and makes you real sick. We just make the tumors in the liver real sick. And that's the idea behind that. Or we can squirt tiny little microscopic radioactive beads, use the same highway, that artery, and squirt them up in the tumor and zap them that way. That's another way we can sometimes treat them. So we have lots of things. Once in a while we'll have a patient where we just can't fix this liver. It's just not a fixable liver, and we have to take it out and throw it away and switch it out for a new one and do a liver transplant. And that's another option. We also, in some patients, we will decide, well, you don't need something done right now, but you will in the future, and we want to pick the best time to give you the best advantage, maybe prolong some aggressive therapy for the appropriate amount of time while we attend to other things like nutrition and whatnot. But by following certain chemical markers, the biochemical markers, the poor man's CAT scan, we can then tell how the disease is progressing and how things are going for when it's time to drop the hammer and now go do something, maybe in the operating room or maybe with one of these other treatments. So we'll follow chromogranin A, we'll follow pancreastatin is another marker we really rely on in our lab, and we follow A5-HIA. We look at neurokinin A, which really doesn't tell us about tumor burden, how much tumor is there, but it helps us decide if the levels are really high, and no matter what we do, we can't bring those levels down. We know the prognosis for that patient is worse than somebody who starts with high levels and we bring them down to low levels. Other patients, when they initially present, have low levels and they stay low, and those patients are going to live forever. But the ones that have high levels that we can bring them down low, their survival curves then start to mimic the ones that had the low levels all along. So that's a good thing. So we like to know that if we can make that kind of a change. The type of things we can do surgically, we can debulk these liver tumors, we can resect them, we can take them out of the liver, we can put special heater probes in them and cook them with microwaves called radiofrequency ablation. It's like a little microwave antenna. It kind of cooks them. Talking about antennas, I had a real nice time today. I went to the NIST, National Bureau of Standards, over in Boulder, where the atomic clock is, and they transmit the time around the world. They are the timekeepers for the world, for the planet. They keep time down to the point 0.00000 to the minus 16 zeros of a second. That's how accurate their clock is. That's pretty accurate. And what they figured out was the world's clock is wrong. We based our clock on how long it takes the Earth to turn around from sunrise to sunrise, and we say that's 24 hours, right? And then we break that down into hours and minutes and seconds. That's how it all started, where we got the value of a second. Well, the problem is the Earth is slowing down, and so now it's not 24 hours anymore. It's 23 hours, 59 minutes and 59 seconds. It's a second off. So every now and then they have to readjust time and have a leap second added in there. Instead of a leap year, they add a leap second. I learned about all this cool stuff today. Anyhow, so we can give a leap second to some of these patients and adjust time. And buy us some time is what we can do. We can sometimes do complicated resections in one part of the liver and cook some tumors in another part of the liver, and then let the rest of the liver alone and not fix it and just say, we're going to leave that part alone for a while because we need this other part to get better and heal and recover, and that part's going to grow back and recover faster than these tumors are going to keep growing. So let that get well. Then we're going to go back a few months later and work on that part of the liver once the other part's recovered. Don't try and do the whole thing all at once, is what we learned. Because sometimes better is the worst enemy of good. We can, again, for certain types of tumors in certain places, we can give a radioactive dose of sandostatin, which will be sucked up by the tumor. And just like we do that to make a scan, instead what we do is we have a handheld Geiger counter, a little wand, and we can use that to find tumors in obscure places, because when we're just like a little metal detector at the beach, it beeps and screeches, and you know if you dig down there, you're going to find a quarter or something. Well, we know if we beeps and screeches, we dig down there through all these layers of stuff, we got a tumor hiding there. We got to go after it. But by the same token, if it doesn't beep and screech, we know we don't have to go there and leave that area alone, so we don't have to go on a blind expedition and unnecessarily explore areas that we shouldn't necessarily have to go after. So it helps us direct our surgery very specifically where we can find these tumors. Very helpful for finding tumors down in the base of the neck. Instead of having to split the whole chest open, we can go through a little bitty hole right here in the top of the neck, but go way down in the chest and find them with a little probe and pluck them out. Works very good in the lower part of the pelvis where it's really hard to see what you're doing, and kind of tight quarters because the pelvic bones are not very giving except when you're having a baby. And even then, there's still not a lot of room. So those kind of areas are good where these probes will help us find tumors and get them out. And we can also do complicated pancreatic resections that we didn't think we used to be able to do before. And people would say, oh, you got tumors too big in the pancreas, it's wrapped around all these vessels, you're not a surgical candidate. And we have found that about 50% of the patients we operate on have been operated on elsewhere and have had what's called a peek and shriek. Close that up and can't touch this, and we can't fix this. And so we are able to figure out ways to get these things out sometimes. Okay? So we can do ultrasound guided radioablation. This is the needle going into the tumor, and these little white bubbles here are micro bubbles where the tumor is turning to steam because we've heated it up to 100 degrees centigrade, and we're boiling the water inside the tumor cells, and it's cooking it like you cook an egg in the microwave. Okay? Push it again. So sometimes we do a big complicated liver resection. That's some of Jeannie's liver that went down to the cafeteria. Okay, next one. And then the big old primary tumor, I know it doesn't show up well, but this is a piece of bowel, but there's a big old tumor here about as big like my fist that was eating the bowel and causing a bowel obstruction. And so because this patient had big old liver tumors, they said, well, there's nothing we can do for you. And I said, well, that's not necessarily the case. Maybe not. And so by relieving the bowel obstruction, taking the big tumor out of the liver that was pressing on the stomach where they felt full all the time because it was pushing on their stomach, now they were able to go back to work and go back to the ball. Keep dancing. Okay? So liver transplant is a little bit controversial because when you do a transplant, you're taking a donor out of the donor pool. Back in the 80s, we used to think liver transplant would be great to do for anybody that had tumors that had spread to their liver that you couldn't fix any other way. Just throw away that bad liver full of tumor, put a fresh one in that doesn't have any tumor in it, you'd be good to go. That experiment in the 80s was a disaster. Nobody did that after a very short period of time because what happens is when you immunosuppress patients after their transplant, like they have to take, the anti-rejection medicine lowers their immunity. The immune system that was keeping all their little microscopic tumors that were somewhere hiding in their body that they were symbiosing with, now the tumors get the upper hand, and it's like putting gasoline on a fire. So the tumors grow wild and spread all over their body, and they would rapidly die of widespread disease. So we couldn't do that. But with this type of disease, since it's a slow-growing tumor, even if it does come back, it may not come back for a long time. And so in somebody who is otherwise going to be gone in 6 months from liver failure, from this tumor destroying so much of their liver, you give them a new liver and you just bought them 6 years before you may have to do something again. Okay? So some liver transplant programs will be happy to do your liver transplant for you if you bring your own donor. Can I have half your liver, please? And so if you have a significant other who wants to give you half their liver, they'll be happy to do your liver transplant for you. Well, that's kind of a big operation for the donor, as you might expect. And so it's not something that's taken lightly, but it's still a doable thing if no other options are available. Okay, so let's go to the next one. So the unknown primary, again, is it asymptomatic or symptomatic? Is it an occult obstruction, or is it just not well-controlled syndrome and they're cramping and diarrhea and all that stuff is because they're just not medicated properly, or is it because they have this partial bowel obstruction that sort of comes and goes from the tumor that has been in there all these years? And then the mesenteric vascular casement is another controversial place where the blood vessels are being squeezed and wrapped. Let's punch it up here. So, well, Dr. Pommier, who many of you in this group probably know up in Oregon, published a paper, and when he just took out the primary tumor, even if he left the disease in the liver, he doubled the patient's progression-free survival from 25 months to 56 months. That means the disease didn't get any worse. Even though they had disease elsewhere, it took the thing out of the mothership, took that out, and for some reason it affected the tumors elsewhere in their body. We don't know why that is. And the median survival went from 47 months to 159 months. That's big, in spite of the fact that they still had disease in their liver. So yeah, we think it's worth taking the primary tumor out if you can find it.
I was just going to ask, how do you find the primary tumor?
It's a complex problem of, let's make an operation and go see. Sometimes we're lucky and we can see it on an imaging study in the scan. Many times, because it may be small, it doesn't show up. So you have to go by where it left its footprints and its tracks. If you see that it's left some tracks because there's some swollen lymph nodes in the mesentery, which is the membrane that carries the blood supply to and from the bowel, that's the highway that tumors travel on too. And so if they've dropped off in some lymph nodes and made those lymph nodes big and fat full of tumor, then you know somewhere upstream from that is going to be the primary. It's just like if you're hiking in the woods and you come to this stream and the stream is bright orange. You know, somebody's dumped some orange paint in the stream. Well, how do you find it? You start walking upstream until you see the guy pouring the can of paint in the water and say, stop that. But you don't go downstream, you won't find it. You got to go upstream. So if we go physiologically upstream from where the last known location is, based on the way the lymph flows and the blood flows, and we start looking there first. And a lot of times it's by feel. You actually have to feel and physically feel the bowel, for instance, because this stuff is in the wall of the bowel. You put a scope in there, you don't see it, it's not inside. You look on the outside with a little bitty laparoscope, and you don't see it because it's in the wall of the bowel. It's between the layers, so you don't see it from the outside, you don't see it from the inside, so you got to feel for it. And sometimes we'll find as many as 70 tumors along a length of bowel in which we thought was only going to be one. They can be multiple. That's the other dirty, rotten trick. So you really do have to feel for them, because if you just stick a scope in there and see, oh, there it is, and you go take that one out, you left 15 other tumors behind that you didn't see with a laparoscope. So we have a lot of patients that come that have been incompletely resected because they had this cool, sexy laparoscopic operation with 3 little scars like that, but they left tumor behind. We just don't have the perfect instrumentation yet for the laparoscope that tells us the tactile sense. Okay, so this doesn't show well, but what this is a tumor sleeving itself inside a piece of bowel, like when you turn your sock inside out. It acts like a lead point, and the bowel sleeves itself into itself. That's called intussusception. And that can intermittently intussuscept and unintussuscept, so they get episodic obstruction. But when they go to the hospital or they do an x-ray or they do a this or that or the other thing, the obstruction resolves spontaneously. They said, oh, you just got gas. Or, oh, you just got psychosomatic problem. Or you just got whatever. You got irritable bowel syndrome. You all heard that? Anybody heard that?
Oh, yeah.
Okay. Okay. Or you're psychosomatic, or you're under stress. You're just too stressed. When you really have a mechanical obstruction that's just coming and going. That's why you take out the primary, so you don't get that. Okay? The difference about this tumor is that with let's say breast cancer, it's the upside down pyramid. The tumor in the breast, when it gets big enough, it's going to spread to the lymph nodes, and when that gets busy enough and big enough and enough tumor burden, it's going to spread to like the liver and somewhere else. It has to get bigger and then go somewhere else. These tumors is the other way around. You can have a little bitty primary in the gut, size of a large garden pea, and then the tumor in the lymph nodes is about that big, and then the tumor in the liver is that big. Now, it all came from that one little thing. So if the theory is right that all of these offspring are genetic reproductions of the original parent and clones, then why is the one in the liver so big and the one that started it, that's been there for 10 years, and the one in the liver has only been there for 2, it's not heredity, it's got to be environment. You know, we talk about twins and how they're the same and how they're different. If you take one twin and raise them in a different household, they got the same heredity, but they end up different from a different environment. The environment of the liver is very favorable to the growth of these tumors, is what we think. And so they go faster there. It's fertile ground. There's plenty of nourishment for them to feed off of. When I meet my maker, if I get to go that direction, it's questionable sometimes. Ask my wife, she'll tell you. I'd like to know, why is that these tumors are so little and have been there for 10 years and never got any bigger, and that the one in the liver is the one that's killing them, it's only been there for a couple of years. Just stuff that makes you go, We're sending these tumors out. When we operate on patients, we send chunks of tumor in all 3 locations, and we send normal tissue from all 3 locations. Then we do a very complex genetic analysis and a gene chip array, and basically what we do is we subtract all the normal genes away that are the same, and take out everything that's the same, so each patient is his own control, and what's left over, we think, are the genes that are responsible for maybe making these things grow faster. We're still trying to figure that out. So here's a little bitty tumor in the gut, right here, and it's about to close off the lumen. This has been filleted open and laid open, but this little thing left all these tumors all over the body. This was in the chest, this is in a rib, this is the liver chock full of tumors, this is in the femur, in the leg bone, and in the pelvis. So that one little thing gave rise to all this stuff all over the place. It's kind of a funny thing. Commonly we'll find unrecognized bowel obstructions, adenopathy, that means pathology in the lymph nodes. We find multiple primary tumors that have to be addressed. And then we'll find disease outside the liver that didn't show up on the scans, because the scans aren't perfect. People can have tumors in places that just don't show up well on the scans, and we got to go find them. And you can't get to some of those spots very well with a little laparoscope. Okay. I promise I'm almost done. So this is a blood vessel. This is some intestines, kind of splayed out, and you see these streaks here. These are the stranding going out here. This is a tumor wrapping around the blood vessels, and this stranding is scar tissue going out from the tumor called a desmoplastic reaction. This scar tissue grows out from the tumor and grabs onto stuff and squeezes and contracts and squeezes, and it destroys the blood vessels and squeezes them shut. That same reaction may be what goes on in the heart valves and destroys the heart valves and turns them to scar tissue, and why they don't work anymore. They get all scarified and stop working, and that's carcinoid heart disease. That same chemical that this tumor makes scars up the heart valves, and in addition to causing these scars in the belly. When these scarring can grab a hold of a piece of bowel and block it off just like a tumor can. And sometimes people get blocked off from that and not the tumor itself. Well, if you looked at this is an arteriogram. This is a catheter in the artery to the guts, and normally it should be looking like the branches of a Chinese fan. And a lot of the branches have been kind of closed, and it almost looks like there's a fist squeezing around here. You see like these little notches in this blood vessel is gone, and this one's almost gone. There should be one here, and this one here is almost gone. This one's still pretty good, but this one's pretty good, but a lot of them are missing because they've been all squeezed off, or almost squeezed off. That's what that tumor did to those vessels. And so we were able to figure out a way to peel those tumors off of those vessels, because this patient actually came to us. He was a 70-year-old gentleman and he would have a belly pain every time he ate. He had that intestinal angina I was talking about. And every time he ate, it hurt, so he just quit eating. It wasn't worth it to him. He was losing weight, and he was kind of getting not much energy. And I said, well, what do you like to do? And why do you want to, your doctors have told you to say, well, one of these days you're going to get a really big pain because the rest of the blood supply is going to go, and all the guts are going to die, and you have gangrene of the intestine, and that's it. Game over. And he said, well, he says, I'm actually a retired minister, and I like to go and give other missionary ministers vacations and locum tenens, and I'll cover their mission for them while they go home and see their family, and give them a couple of weeks off. And I like to go around the world and do that. And he was also an amateur photographer. He liked to take pictures of all kind of really cool places like Kilimanjaro and the Nile River and the, whatever, jungles and the desert and this and that. All over the world this guy would go, and he couldn't do that anymore. And I said, he was the first guy that came to me that had this problem. And I said, well, he said, can you do my operation? I said, again, my usual answer is, I don't know. I'm not sure. I said, I'm willing to try, but I have to tell you that I think there's a good chance I could hasten your demise. If it goes badly, when I start peeling these tumors off and the blood vessels just fall apart and crack and burst or crumble, because the tumor is so destroyed and made the blood vessels so crumbly and not good quality anymore. And so you won't be able to sew to them anymore to patch up a hole. You just have to tie them off. And then whatever blood supply is tied off, that's going to kill whatever's downstream because it doesn't have a blood supply anymore. So I could really put you in a grave. He says, well, I can't go on living like this. I want you to give it a shot. I said, yeah, this guy's a brave guy. I said, okay, I'll give it my best shot. 14 hours later, we got the tumors out. That's how long it took to peel all that stuff out of his guts. 10 years later, he's still giving locum tenens to missionaries around the world at age 80. So here's some of those blood vessels being peeled off, and this is a big tumor coming out of them. And this is an operation that most surgeons that are trained in cancer surgery will tell you, and I will tell you, that for any other kind of cancer, you can't do this, because those tumors, if they're in that location from other kinds of cancers, they don't just encase. Uh-oh. Big dog's going after the little dog. And that would be a one-biter. It would be like a cupcake. A little snack. Oh my. Ruh-roh. Woo, that was kind of exciting there. Well, y'all awake now. Okay then. Thank you for that. So, other types of tumors will actually grow into those blood vessels and grow into the wall of the blood vessel. And if you try to peel that tumor off the blood vessel, you're going to look at the inside of that blood vessel and blood's going to be squirting you in the face. You can't do that. But these tumors, perhaps because of this desmoplastic reaction, because maybe they grow so slowly, they don't grow into the blood vessel many times, they just grow around them and encase them. And so if you can peel them out, and sometimes it's like trying to chip an egg out of a block of concrete and not bust the egg, is kind of what it feels like. And kind of, kind of what it's like. But the concrete's not in the egg. If you can get it out, you still have a good egg when you're all done. So sometimes we can actually do this. Not every time, but in the last 87 or so attempts, I had to say cancer wins 3 times, where I just couldn't do it. Anyway, and there's some more blood vessels all peeled out, and this was the big old tumors that were wrapped around that we peeled off of it. Okay, and this is another that doesn't show up so well, so just keep going. So, anyway, but you get the idea. And so, in our first 80 some odd cases, a whole bunch of patients had this problem that were kind of able to figure out something. They either had that encasement or they had a blockage that was previously unrecognized. Okay, next. And so 50% of the patients were operated on elsewhere and declared unresectable. And the problem with mesenteric ischemia, bowel obstruction, carcinoid syndrome not controlled, irritable bowel syndrome, Crohn's disease, and ulcerative colitis, the symptoms overlap. They're very difficult to sort it out. So you can't just always tell. You don't always know. Okay. So this is our little handheld NeoProbe wand that's in a sterile plastic sleeve. And it's on a lymph node here that otherwise looked and felt totally benign. But when we, when we put the probe on it, it lit up, man. Normally this should be reading about 2 or 3 and it's reading 500 counts. So that was a hot one, so we knew to take that one out. So that was radio-guided surgery. So you can't always tell just by looking or feeling. And then another time we had a patient, this was an interesting one. This lady was complaining, she had a bunch of carcinoids in her belly and we cleaned all that stuff out. But she said, oh, by the way, I've been having this ringing in my ears for the last 5 years. And it comes and goes and almost feels like it's going with my heartbeat. Well, we'd never heard of that before. It's called pulsatile tinnitus. Tinnitus means ringing in your ears with every heartbeat. That's what it means. And so, anyway, this is an Octria scan. Maybe we give them that radioactive sandostatin stuff, and it binds to the tumor where it is and lights it up. Now, it always gets concentrated in the liver and the spleen and the kidneys, so forget about that. That's kind of normal, and it ends up in the bladder, and that's normal. But there's no tumors in the belly anymore. But what there is these 2 things up here in the kind of in the chest and kind of in the neck. And they didn't really show up really good on the CAT scan, but they were really hot on the Octria scan. But when we fuse the 2 images together, which is another new technology, where we superimpose this 2-dimensional X-ray on a 3-dimensional picture and then turn it sideways, so now we're looking at the patient from the side. Now we have this hot spot here. Here's the spine. You can't see it very well, but there's this artery running up right behind this tumor. And so here's the front and here's the back, and the chest is here, so the lungs are real close by. And so here's like, this would be like the top of the sternum here. So it's right here at the base of the neck, just behind the collarbone, up against the spine. And this tumor in this lymph node was pressing on the vertebral artery, which goes up to the back of the head. So when we use that little wand to find this thing through a little small incision in the neck and plucked it out, she woke up and said, my ears don't ring anymore. Kind of neat, huh? So you never know what life is like a box of chocolates. You never know what you're going to find. So the other thing we thought about was, why do some people get a bunch of tumors all along the bowel instead of just one? We saw that more commonly when there was a bunch of tumors and massive stuff in that mesentery where we talked about, where at the base of the blood supply there was a bunch of tumors all wrapped around there and squeezing. And so we think, well, maybe if the lymphatics can't drain the way they normally go because they're blocked, they drain down the bowel, and as they drain, they drop off tumors along that river. Okay, that river is the highway that tumors travel on to go places on the lymphatics, as well as the bloodstream. But if they're traveling in the lymphatics and the main channel is blocked, to get down the mountain, they're going to go around and go north or south along the bowel before they want to go where they want to go back to go home base. So we thought maybe that's why they have multiple tumors, because they dropped some tumor cells along the way as they were traveling down this river of lymph. So, go ahead. So the other thing is, we had patients that had what was thought to be an adequate resection that had recurrences at their suture line. And the classic teaching is, again, we're shifting our paradigms here. The classic teaching is, with a small bowel tumor, you just need to get about 5 centimeters away from it and take that out and wedge it out all the way down to the base of the mesentery, and you've got the lymphatics and you're good to go, and see you later. Not a problem. Well, maybe that's not necessarily the case. So the other thing is that we want to try and do is, when we're dealing with small bowel tumors, because a lot of times these tumors are located right close to that valve at the end of the small bowel where it meets the large bowel. Now, when you have to lose the small bowel valve, that ileocecal valve, which a lot of times has to be done for various and sundry reasons, and especially for carcinoid tumors in that location, just losing that valve can predispose people to having diarrhea. Now, if you have diarrhea because you have carcinoid syndrome, and maybe your gut's kind of been shortened because you've had several operations, and you no longer have an ileocecal valve, and you're on sandostatin, which can shut off your pancreatic enzymes, so you don't have enough enzymes to help digest your food, and you get a different kind of diarrhea called steatorrhea due to the fats in the diet. It acts like a cathartic, like castor oil, and makes you go. So you have about 6 reasons to have diarrhea. If you can eliminate at least one of them, maybe you can help those patients by sparing that ileocecal valve, because they got all kind of reasons to have a problem, and you're trying to fix their problem. So what we did was, here's a tumor in the bowel, this little white thing with this pucker. That's that desmoplastic reaction drawn in. And it's all, you can see everything's kind of drawn into, normally this would be nice and smooth and flat, but it's all puckered and folded up, and there's a tumor sitting right here in a bunch of lymph nodes. Got it all squeezed in there. So next one. So what we did is we inject this blue dye right into the tumor, and it starts traveling on there. This is not a vein, this is a lymphatic. And that's where the lymph nodes are draining to. Okay, but it normally goes this way towards the center, not down the length of the bowel. So go to the next one. So if the tumor is here and the lymphatics go this way and then turn and go up where they're supposed to go towards the base, that's normal. And now you're just shy of that ileocecal valve here, and you can cut the bowel there and save that valve, and they won't have so much diarrhea. And that's a good thing. But if, go ahead, next one. If they have a bunch of tumors and a big tumor in the base of the mesentery blocking up the main lymphatic channels, now the lymphatics go this way and they cross the ileocecal valve and go into the colon and then go up or down here. Now you have all these other little drop metastases, these other little tumulets along the length of the bowel, because there's no place else for the lymph to go. Now you have to take the ileocecal valve, and you got to get all those other tumors out too. So next one. So here we injected the tumor way down here, and this lymphatic traveled 25 centimeters before it finally took a left turn and went down towards the base. So that little 5 centimeter margin wouldn't have gotten it. And that's changing the way we think about doing bowel surgery. So that, my partner worked that out. Dr. Wang figured that out. But I'll be first to steal a good idea. So basically, what we found out For these first 85 patients that were on pain patches and on hospice and on everything and didn't have very good performance scales, once we were all done, their Karnofsky score, which means anything less than about 80, and you can't care for yourself, and their scores were about 65. 0 means you're in a casket, not breathing. Anything over 80 and you're able to function. They went home with scores of 85 or better. So we thought it was kind of worth doing. For that first 80 kind of gave us the idea, well, maybe we need to look at this further. Because until we really looked at our results and analyzed it, you don't really know, are you really doing some good or not, right? You think you are, you'd like to think you are. We found out that intestinal obstruction and vascular encasement were underappreciated, underreported, and undertreated. And it still is today. And this paper was published 6 years ago, I think. Even with advanced disease, long-term survival is possible, and we still think that's true today. And an aggressive debulking program may mean needing multiple procedures, but can significantly improve long-term survival and symptoms. And in our hands, the extent of disease was best evaluated by an open operation to go and really have a look-see. All the scans and all the stuff we do have been wrong about 50% of the time. Okay, next. And we do a bunch of tests with the tumor. We send it off, we grow it in the lab, we do all kind of neat stuff with it to test it, to see what makes it grow, what makes it die, how do we control it. And so we really try to analyze these tumors on an individualized basis to tailor their therapy based on what their tumor does when we grow it in the lab, as opposed to pickling it in a jar of formaldehyde and say, tell us what that was. We want to know what it's doing, not what it was, so that we can hopefully affect what it's going to do. Next one. So we had all these other things. We try and, with a multidisciplinary team, decide which non-surgical approaches are best and in which sequence we should do them. Because if you do one thing first, it may burn a bridge for doing something else later. So you want to have the right sequencing. Okay, next. And then when we do think they're a surgical candidate, we want to address comorbidities like heart problems or liver problems or kidney problems or nutrition, which is a big one. To get somebody safely through a big operation, they got to have the glue and the stickum and the stuff it takes to heal all that. And to do that, you got to have good nutrition, or you're just not going to heal well. Okay, next. So we have a big team that does, all these different things and all these different specialties. And I think I wanted to talk to you a little bit about that. As a result of our efforts and our collaboration with this team, we were able to publish the National Guidelines for the Management of Neuroendocrine Tumors, the Diagnosis and Management. And it's a free publication online in the August issue of Pancreas of 2010. And you can go to pancreas.org, I think, or pancreas.com. I'm not sure which now. I'm sorry, my brain's a little fuzzy. I had one too many chocolate chip cookies, I think. My insulin didn't kick in just yet. Anyway, but that's accessible, and your physicians can go online and look, and it's a whole big series of articles. It was mostly written by our group and other experts in the field that gives people ideas about diagnosis and management of what to do, what tests to order, what markers to get, what scans to get, stuff like that. Very useful chunk of information. And you can go online, and they have made this issue available for free. You don't have to have a subscription to the journal and stuff, which is very nice of them to do that, because they thought it was a valuable resource. And it's the North American Neuroendocrine Tumor Society's, NANETS for short, guidelines for the diagnosis and management of neuroendocrine tumors, from soup to nuts, from the head to the toe, thymus, lung, pancreas, GI tract, you name it. It's in there. It's like ragu. It's in there. Next. So, now I'll tell you a little story. You got a couple more minutes? Is that good? Or y'all dying here? Bugs aren't too bad? Okay? Okay, so you may recall that about 6 years ago we had this little weather problem called Katrina. And that's a picture of it. This is the Louisiana coast. I live right there. Okay? That's not a good place to be at that particular time. Largest storm to hit the Gulf of Mexico in the last 100 years. And the thing about hurricanes is the wind is blowing like hell, then the eye passes over and you think, oh man, we made it through that, everything is great. And then the wind starts blowing like hell, but from the opposite direction. So all the trees that were leaning this way now are leaning this way, and they tend to not just lean, they tend to come over. And they land on people's houses and stuff. Anyway, so, next one. So, there was a whole lot of water. So much water that it inundated an area 5.5 times the size of Manhattan. 200,000 homes underwater for 6 weeks. It wasn't the hurricane that did that, it was the levees that broke. They were built poorly by our Corps of Engineers, but that's another discussion. It was a sunny day, it was a beautiful day like today. The birds were singing, the storm was past when the things busted and the water poured in. The Gulf of Mexico emptied itself by way of Lake Pontchartrain into our city. And so this is houses buried to the eaves. This is the interstate of I-10, about 8 blocks from my house. This is a hospital. As you can see, it's kind of an island now with water halfway up the first floor, and the basement, of course, filled up with water, which is where the generators were. Who thought of that? Put the generators in the basement. Give me a break. So sometimes you're away without a home, and sometimes you don't have a home to go back to. All you have is a foundation. Sometimes you feel like a ship without an anchor. Those boats were piled up about a half a mile inland and about a half a mile from my house. Sometimes you don't know the road home because there is no road. You passed it up. Back up one. This is Interstate 10. I don't know if you can shift it a little bit, move the thingy over this way to show that. That's Interstate 10. The waves and the storm surge in Lake Pontchartrain came up and lifted the sections of the interstate off the piles and just tossed them in the lake somewhere. They still don't know where they are. That was Interstate 10. So you couldn't get back into town. And that's what the waves and the wind did from the storm surge to the highways. But we cobbled together some people. We lost our clinic. I was in exile and I moved in with Mom in Baton Rouge for about 9 months because we couldn't get back in our house. But I was able to borrow some clinic space from a friend of mine in Baton Rouge, and I got a hold of Dr. Woltering and Dr. Anthony and said, you guys want to drive to Baton Rouge a couple of days a week and we have a clinic? And we'll have the patients come see us all together at the same time on the same day in the same place. And they said, yeah, we'll do that. And so patients started coming, and they kind of liked that. And we brought our nutritionist and one of our old transplant nurses, because my transplant hospital was underwater and it wasn't coming back. It still has not reopened. I did my last transplant about 3 days before the hurricane. So when we were able to get back into our homes about 9 months later and find some clinic space in New Orleans, which happened to be close to an airport, because we thought that might be a good idea, I was able to again borrow some clinic space from a friend of mine, because clinic space was at a premium because there were no offices, there were no clinics, there were no hospitals, there were no homes for people to live in. I mean, people didn't have places to live. I mean, 200,000 dwellings just ceased to be. And anyway, so I was able to get my hands on one clinic exam room for 7 days a week that I could rent. And the other 2 exam rooms I could have 2 days a week when they were in surgery, the orthopedists. I borrowed their space. And so one exam room, we had 3 picnic tables, 2 computers, and a phone for 3 docs, a nurse, and a nutritionist, and that was our office. And the other 2 exam rooms that we had on Tuesdays and Fridays was where we saw patients for clinic. And now, I'm happy to report that the music is played again. Now we're in a 7,000 square foot space with 17 employees, 9 docs, and we see 40 new neuroendocrine patients a month, and we're following over 1,000 patients. We're about to report on our experience with the last 480 mid-gut carcinoids we've operated on, with our 5, 10, 15, and 20-year experience, which is going to be the largest single center experience reported in the world, with 5, 10, and 15, and 20-year survivals, exactly twice the national average, and 20% better than the best program in the world, which is in Uppsala, Sweden currently, and it's twice as large as their reported series. We hope we can get it published someplace and somebody will believe us. Anyway, my papa told me that, son, if you throw enough stuff up the side of your barn, some of it's going to stick. And we're fortunate to have a lot of experiences and things thrown upside our barn, and I was able to work with a really good team. And when you get to work with a good team, you get the next one. Sometimes good things happen. And a whole lot of people wait a whole long time for that one, I can tell you. At any rate, that's about all I have. We do have a phone number that's toll-free, 866-91-ZEBRA. Not too hard to remember. And we view ourselves as a resource. If you folks need assistance, if your physicians need assistance, or just want to kind of pass an idea or a question about something to folks, we'd be more than happy. We view ourselves as a resource, and so we would like to continue to be that resource for anybody who needs. Thank you very much. I hope I didn't talk too long.
No, are you going to have some questions, right?
Yeah, sure.
But may I, well, let's see. Can I say thank you and then we'll do questions? Sure.
And if anybody needs to go, please don't feel like you have to stay. I know it's a long day tomorrow and people have been here a long day and it's been hot and stuff, so please don't feel like you got to stick around. If you got places to go and stuff to do and people to see, that's totally cool.
I just want to, first of all, thank you, Dr. Boudreau.
You're quite welcome.
Amazing and wonderful.
Thank you. It's
So
people
thankful
like
I ran
you.
into you.
It's people like you that are willing to take a chance and give us a shot.
Yeah.
Then we get a chance to learn how to do things better and be better at what we do. Without brave people who saying, yeah, you can go ahead and split my belly open and see what you find. That's basically what you did.
Yeah. And I'm here 7 years later, which is...
I guess it was worth the trip then.
Yeah. So we'll have some questions and answers in a little bit, so don't leave me. So I just wanted to first of all say thanks, family, for always being here. John and Kelly and Sean and Cammie and your spouses and your children, and always great support. Friends, Scarsonite friends. Wow, I was so touched when you all stood up tonight. That's the most we've ever had at our race, and thank you so much for coming and surviving. And don't give up and listen with your ears and your heart and your gut, because I mean, it saves us, and there's things that can be done. And dear friends, new friends, old friends, hang in there, and thanks for coming, and see you tomorrow at the race. Dr. Boudreau and I are going to race each other in the 1 mile, right, Ben?
Right. If you promise not to beat me too badly.
Okay, here's your mic.
Okay, thank you. So it's events like this and people like you that makes me want to get up in the morning and do it again. Thank you.
I forgot to say thank you for the Poudre Valley Hospital Foundation. My gosh, they're the ones that did all this work these last 2 years and let me go on vacation. That's right. So thanks, guys. Deb and Shannon and Nick and Joanne and Annie and Heather and can't remember all your names. Thank you, thank you, thank you.
Good job. Somebody had a question, I thought. Yes.
I was diagnosed